My guest today is a PA who has worked in neurology for many years, and she's going to talk about the great sides of neurology, the things that people may not realize that make it an interesting and fulfilling specialty to work in. She's also going to talk about some of the downsides and what it's really like treating patients with neurological conditions. On top of that, she is someone who believes in salary transparency. So she's going to share with us exactly how much she has made in neurology, as well as sharing what the national salary range is in the specialty. So, if you're even remotely interested in this specialty, you're really going to want to listen to this interview. It is chock full of information. Hi, it's Michelle with the Medicine Couch, and I really appreciate you joining me today. If you know colleagues and friends who would find this video informative and interesting and helpful, then please make sure you share it with them. All right, let's head into this interview and learn all about working in neurology as a PA or an NP.
Hi, my name is Brittany Adair. I'm a physician assistant, graduated from Sullivan University in Louisville, Kentucky in 2018. My first job straight out of PA school was neurosurgery, and then I moved states, so I migrated into outpatient general adult neurology, and then I eventually migrated into teaching full time in a physician assistant program.
And also, you've been in the reserves or something, right?
I had commissioned into the Army National Guard straight out of my undergraduate program in 2010. And then in 2018, after I graduated from PA school, I transferred to a physician assistant role in the Air Force. So I have experience in both the Army Guard and the Air Force National Guard.
We will be talking about that towards the end of the interview, but I will probably break this up into two interviews. So if you're interested in hearing about Brittany's experiences working in the Guard, both with the Army and the Air Force, then make sure you watch for that video. So let's talk about neurology because that is the specialty that you've worked in most. Tell me a little bit about that transition first from neurosurgery to neurology.
I migrated into neurology from neurosurgery for several reasons. One, I was moving states, so it was just the right time to try to change practices as well. And family work life balance. I was planning on having a family, and neurosurgery or most surgery positions just are not as conducive to a good family work life balance. And I still love neuro, so that's why I decided to go into outpatient general adult neurology. There are lots of different fields you can go into within neurology itself, and that's just the one that I chose to.
Talk a little bit about some of the different common options that you see as kind of subspecialties in neurology, meaning that when people go into a practice, they may concentrate in one of these particular disease areas.
So there are very few adult general neurology practices. Most providers in neurology do subspecialize.
Oh,
There is a
okay.
difference between adult neurology and pediatric neurology also. They're very different disease processes that you treat in both of them. And then you have the outpatient neurology setting and then inpatient neurology setting, which again are very different processes. With the adult general neurology practice, you see everything in neuro, and you'll get referrals for things people just can't figure something out. So they send a patient to you to try to figure out. You'll get multiple sclerosis, neurodegenerative diseases like dementia, movement disorders, your Parkinson's disease, Huntington's disease, epilepsy, stroke, migraines, headaches. You treat all neuro diseases in adult general neurology. And then you have your subspecialties. Your big ones are multiple sclerosis clinics, epilepsy clinics. So you have an epileptologist that runs, they just treat epilepsy and seizures, migraine and headache clinics, and then movement disorder clinics. Those are your big ones where providers were subspecialized, and those are the only patients they'll see. I worked in an outpatient adult general neurology practice, so I had the pleasure of being able to treat patients with any kind of disease process, and it was a journey. I had a wonderful collaborative physician that taught me along the way so that I was able to have some autonomy in treating my own patients. But it's definitely a little more difficult when you do adult general neurology because you just don't know what's coming through the door.
Can you tell us a little bit about kind of what that training was like?
I was very lucky to have a wonderful mentor in that sense. The collaborative physician that I worked with trains all of his advanced practice providers for several weeks and his nurses before he gives them the autonomy to treat their own patients. And that includes shadowing him first to see what the field is like, how he does certain procedures and certain exams. And then he lets you see the patients first, similar to what you would do on a clinical rotation in PA school. You would see the patient and then present it to him. And then he lets you see the patients, do the notes, and he'll take that. And then that's your kind of last week before you're off on your own. So I had a wonderful collaborative physician that does that. I know not every practice has that ability, and not every collaborative physician is willing to do that training. He was
Yeah.
wonderful in that sense. And I don't know if I would have succeeded in neurology without that guidance. And mainly because where I ended up being located at geographically was an hour and a half away from him. And I was the only
Uh-huh.
neurology provider in the office at all.
Did he assign readings, or did you go find courses and things that you took on your own, or was it pretty much just the mentoring that he gave in the office?
He gave resources to do studying on your own, which I think as medical providers, you have to do that no matter what field you go into. For neurospecific, Cleveland Clinic is a wonderful resource. A lot of your academic centers do have specialize in neurodiseases and rare neurodiseases. So they offer a lot of training and videos to help guide you in diagnosing neurological diseases. So any of the academic centers, their websites are wonderful for that purpose, and Cleveland Clinic is one of them. And then there are conferences. So Cleveland Clinic again offers a conference in August that can be online or in person. It's just a simple 2-day conference where they go over everything in neuro to get you just a broad overview and then updates in it. And then the American Academy of Neurology, you can join that as an APP, just like you can join most of the other academies. And they have a lot of resources, video training. There are some books, and I use these books really primarily when I started teaching neurology, but I do have a couple of books that kind of help you. Introduction to Clinical Neurology is one resource, and then Aids to the Examination of the Peripheral Nervous System helps you with your neuro exam. This
Yeah.
is super tiny. The 4-minute neurological exam, again, a very small book, very easy read to help you. And I would recommend that for anybody in any field to get, just to get more comfortable with your neuro skills. Because you see, headaches, back pain, neurodegenerative diseases are so prominent. So
Right.
you don't always have to send them to neurology. And then the last one is this book. It's a Handbook of Neurosurgery, Neurology, and Spinal Medicine for Nurses and Advanced Practice Health Providers. And this one's a really easy read. It gives you really comprehensive for all things neuro, not just neurology. So those are some resources that would be beneficial if you're wanting to go into the neuro field, the larger ones, and then the smaller ones for anybody, just if you want
Yeah.
to get better at doing a neuro exam.
And because neuro, the exam tells you so much. It's like you can do a neuro exam and you can pinpoint like exactly where the lesion is or the problem, which is really fascinating, but it's also daunting, right? Especially if
It
you don't
is,
know
yes.
that.
I love how you use the word lesion because that's the word we call it lesion localization. So you can determine
Yeah.
if it's central or peripheral. And you do have to be really good at your anatomy and basic physiology and your physical exam skills. And you can track anything back with just that to where it's originating and make a clinical diagnosis in neuro. And that's what is so fascinating about it.
Do you feel like in neurology that there are a lot of good treatments? Like, do you get the satisfaction of actually being able to help these people once you figure out what the diagnosis is?
So, one of the unfortunate things of most neurodiseases is that they are degenerative and there's no cure for them. The majority of diseases that you treat in neurology are just treating the symptoms, unfortunately. I don't feel like the medicines are really necessarily up to par for what we want to do in medicine. We
Yeah.
want to cure people, we want to be able to provide that to them. But unfortunately, you do have to have the mindset going into neuro that you're helping to provide these patients a better quality of life. And that is commendable. I mean, you can't cure them, but you can definitely give them a better quality of life. Most of your therapies are off-label uses. So we all know what off-label, not FDA approved, but medically we use them. And
Right.
so there's a lot of patient education around that and trying to decide, which therapy is really the best to use because your treatment algorithms don't necessarily work for neuro diseases. And a lot of your medicines are not going to be your oral medications where you just give them a tablet. There's a lot of therapies that are injectables, whether it's a once monthly injectable they give themselves or they have to go to an infusion center. Since there's so many more therapies in neuro that are needle based, it's a lot more important for that patient education there, and
Hmm.
trying to decide, what medicine are they going to be most compliant with, which one's going to give them the least amount of side effects, You do titrate a lot of these therapies up to really high dosages. So you have a much higher propensity for those bad side effects. But that's where most patients will get relief from their symptoms, unfortunately.
So let's circle back a little bit to when you were talking about how you ended up working all by yourself in a clinic. Tell us a little bit more about that and what that was like and some of the challenges that you faced.
So the individual who was supposed to be my collaborative physician left right before I started. And so my collaborative physician ended up being an hour and a half away.
Mm.
And his office was a full neurology office with 4 APPs. Just neuro diseases is all that they saw. And then I ended up practicing in an office that became a multi specialty clinic. We had bariatrics, primary care, OB-GYN, neurology, all in one big office setting. And so there was a lot of educating, not just the patients, but educating the staff that I was responsible for since I was the only one on site there. But he did come up one day every week and he was always available by phone. So I never felt like I didn't have help.
Then were you seeing new patients and kind of doing that initial evaluation also?
I was, yes. So I was taking over all of the patients from the previous provider. And then also I was seeing all my own new patients. So I had patients that were established with neuro just by default by taking over somebody else's patients. And then I was the one that would see all new patients to the office as well. So I was
Yeah.
doing new patient workups. If I felt like a patient was out of my depth and breadth, my scope, my supervising and collaborative physician would see them on the 1 day a week that he was there.
I do think that it can be a perfectly fine model for the PAs or NPs to see the new patient first because they're doing all the fact finding, getting the patient established, kind of really getting a sense of what is going on with this patient. And then if need be, they can escalate the care to the physician. But did you encounter issues with patients when they came to neurology and then they're seeing a PA initially?
I did sometimes, and I can understand a patient's frustration when they waited 6 months for an appointment and then they're seeing the PA because there was no MD on site. So I can understand their frustration with that. And so it's just having that empathy and that approach to those patients that, hey, if you aren't satisfied with my level of care, we'll definitely get you in to see an MD. But just trying to quell those initial jitters for the patient at the beginning does help. And then I did have some referring providers that specified on the referral that they would only want their patient to see an MD. They didn't want
Yeah.
them to see a PA. And everybody does have their preference.
From what you have seen in neurology, does it tend to be PA heavy, NP heavy, or is it just kind of a mixture of both?
In my geographical location, it was very NP heavy, and even neurosurgery in my geographical location. And that's just where I live. It is open to both. And I did attend a neurology conference with an APP track, and there are tons of PAs and NPs in the field.
So, kind of what was a typical day like for you? Like, what time would you usually get into clinic, and how long did you have with each patient? And then, what time were you usually getting out? Those kind of things.
Yeah, so at the very beginning, since I was taking over another provider's sudden departure patients plus new patients, I started coming into the office and seeing patients at 7:30 in the morning. And I would put patients into some emergency slots that I had during lunchtime since they had such a long wait for a typical slot. And then my last patient of the day was around 3:30 in the afternoon. Some of my new patients would take an hour, some of them would only take 30 minutes. All of my appointment slots were 30 minutes in length, whether it was a new patient or an established patient. And that was to compensate for those new patients that took an hour versus the established patients that only took 15 minutes. And that was part of educating some of the office staff as to what neuro diseases and how much time it actually takes to identify them and treat them. And you're getting a lot of patients that this is their last stop. They've seen so many other providers. They have, this many medical records for you to review. And so just reviewing their medical records to try to see if there's something that has been missed or if there's something else that could possibly be done to help the patients. It takes a lot of time. And so day to day, it would just be whatever kind of comes in for the day. And then I would have emergency slots for patients that got a stat or urgent referral. I did see a lot of pharmaceutical reps because a lot of the therapies that you use in neuro are either off label or brand new branded medication. It helps to have a good relationship with your pharmaceutical sales reps in those therapies because they have a depth of knowledge on those medications that you just can't get otherwise. And they also have nurse lines that help you with the prior authorizations for those therapies. And so every lunch period that I had was taken up with a pharmaceutical sales lunch. The staff loved it. They got free lunch
Yeah.
every day. And then I also, it was a different rep every day. And I learned a lot of therapies that way. Even though it's time consuming, I do think it's something that a lot of people don't utilize enough.
How many patients would you say a day on average were you seeing in neurology?
I saw about 15 a day since I was seeing both complicated and follow up patients.
So the PAs and NPs that worked in the office with the supervising physician, were they seeing about the same or were they seeing more or less?
They were seeing about the same. We were able to keep the APPs, our schedules, to 30-minute appointment patients. Now, our
Okay.
collaborative physician had 15-minute appointments for
Mm.
most of his
Yeah.
patients. And he had procedure days where he would do just EMGs and nerve conduction studies, different types of therapies, lumbar punctures.
Did any of the PAs or NPs do any procedures themselves?
Yes, we did. So I did several procedures myself, including botulinum toxin therapies for migraines. I was training to do botulinum toxin therapies for spasticity, but never got around to actually performing those. Vagus nerve stimulation management. So you're not the one that's putting in the vagus nerve stimulation, but it's a device that's used for seizure control for refractive epilepsy, and you can manage the settings in the office. Shunt management, so somebody who has a shunt placement for any number of reasons, you manage the shunts in the office. Occipital nerve blocks for occipital neuralgia. I did trigger point injections for myofascial pain, lumbar punctures for the diagnosis and the therapeutic treatment of
Okay.
pseudotumor cerebri. There's a thing called sphenopalatine ganglion blocks, and it's a treatment for acute migraine attacks, lidocaine in the back of the nose. And so we would do those, and then potentially pain pump management and skin biopsies for small fiber neuropathy.
I didn't ever think about this before, but in neurology, did you end up writing much, if any, opioids?
You have a potential of utilizing narcotic therapies if needed for the right patients. A lot of your neurodiseases use your gabapentinoids and other therapies to treat neuropathic pains more so than narcotic treatments. And so I was more so using gabapentin, Lyrica, those types of therapies for neuropathic type pains more so than opioids. But there is a potential for patients. And if you're not comfortable with it, we worked closely with pain management.
What are some of the things that have surprised you in the specialty of neurology?
Some of the big surprises were just the misconceptions about neurology and the amount of education that you do for your staff, not just for the patients. And then you're not just treating neurological diseases themselves, you're treating everything else that goes along with it, all the other associated symptoms, pain, anxieties, depressions. And you have to titrate a lot of these therapies up very, very painfully slow. And so you're bringing patients back quite frequently at the very early stages to assess the response to treatment, how high you need to go. And a lot of the therapies that you do use very high dosages that a lot of people may not be comfortable with because it's not something you would typically do in primary care. And then just the amount of prior authorizations and peer to peers that you do, because most of your therapies are off label. You're ordering so many different specialty diagnostic evaluations just to try to rule out other things, and I know you have to do that in every field. Just felt like it was every day in neuro because most
Yeah.
therapies are off label, unfortunately.
And along with that, like charting, getting charting done, were you taking charting home?
Oh, most certainly.
Yeah.
I probably made my notes way too long, but I wanted to type out everything the patient told me and not just summarize it. Because there's just certain things you can't summarize. If you are detailed enough in the notes and the patient tells you exactly what's going on, you can look at it and be like, well, you may be getting worse in this aspect, but this aspect has improved. And so you don't want to change therapies too frequently because eventually you run out of something to use.
Right.
So it's really important to really know if a therapy is actually working or not, or if it's a side effect from the therapy, or if it's just the disease itself getting worse and there's nothing your treatments is not what's bad, it's just the disease is getting worse. So those little things make a big difference in the end. And
Right.
so It was very time consuming, and I was always taking notes home with me. I was looking at patient medical histories that I just, didn't have time to look at in the office, and then researching to make sure that I'm doing the right diagnosis. You want to be very sure of your diagnosis. You are giving your patient a diagnosis of a disease that they're going to live with the rest of their life, and treatments that can be very debilitating, not just the disease itself.
What do you think are some of the hardest parts about working in neurology?
It's the emotional toll that it takes on you as a provider. And that was something that I wasn't fully prepared for when I first went into it, because your patients are always getting worse. They're never getting better. And so that is very difficult sometimes to manage from an emotional standpoint, not just for you personally, but also you're giving that emotional counseling and coaching to your patients and their family members. And they're constantly asking you about their prognosis and when are they going to get worse. And it is very emotionally draining. So that is something you have to go into understanding that about neuro. And it's also a blessing though, because you get to see these patients that are just so resilient. You know that you can't cure them. And in medicine, we always want to find a cure. But even though you can't cure them, they're just so resilient. And it's very, very humbling experience when you get to treat them. It has definitely been a blessing in my life.
I can see how that can be really touching to see and also inspirational, to yourself to know what people can handle their lives and how they can go on leading happy, exciting lives, even with these terrible diagnoses. What about personalities that you think would do well in this specialty?
You have to be a chameleon. And so what I mean by that is you're living in the gray area because it's not black and white. And you have to be okay with not always having the answer. There are some things in neurology that are we're still learning, and we may not have the answers to everything. And you have to be okay with that and with being able to give that type of news to your patient as well. You do want to be confident in your skills, because most of your neuro diseases are clinical diagnosis. You're tracking back your physical exam findings, your history, to basic anatomy and physiology to figure out the origin of where something is coming from. So you have to be very, very confident in your skills, but then you also have to be very empathetic and be willing to second guess yourself and do the research to make sure that you are definitively right with what you're diagnosing your patient with. So you have to be confident, but also second guess, and then have empathy when you're giving that news to your patients. And I think that's where most of us might falter.
Yeah, especially when you're so busy and have so much to do
Mhm.
and time is pressing and you're just overwhelmed and exhausted yourself. Yeah, it's definitely a challenge. Let's talk a little bit about salary. Salary is never, I think, what people should use to pick a specialty to go into.
Mhm.
But of course, salary is important, and people like to know how much they can expect to make if they go into a different specialty. So, when you worked in neurology, I know you shared with me that you are comfortable letting people know exactly what you made. Can you tell us about that? And then also maybe if you can tell us about what range you've seen around the country.
Yeah, so I do think it's important for PAs in general to just be open about sharing their salaries. The only way for us to negotiate for more.
Yeah.
And so, in the field of neurology, in East Tennessee at least, the facility that I worked at gave a flat rate, base rate to all advanced practice providers, PA and NP across the board, regardless of your specialty, which was 105,000 when I first started out. And that was the base salary, and there wasn't really any negotiating. And then we all had the same benefits package. The thing that was different for each specialty was how much bonus you can make based off of your RVUs. But since that facility unfortunately had that flat rate, there was no negotiating it. In general, across the US, of course, it's going to be geographically different, but based off of the last AAP salary report that I read, it was about 90,000 to 135,000 was the range for starting out. And then obviously your time in and other bonuses weren't taken into account for that base pay.
So you had said earlier that you had 30-minute appointments and seeing 15 patients a day. So were you even able to hit RVUs to make bonuses in neurology?
No, I calculated that once. I would have had to see 45 patients a day to make like the minimum RVUs that they expected to make that bonus. So it was unrealistic.
Yeah.
But I didn't know that when I first started out because I didn't know what to expect for my RVUs. I didn't know at the time how much different things were reimbursed. So knowing that now and knowing the reimbursement rate for different procedures has been very beneficial. And I would encourage anybody in any field to look up those reimbursement rates too when you get a new contract to determine, is this acceptable for where I'm at and what I'm going to be doing in this field.
I'm really surprised at that salary,
Mhm.
honestly. I mean, I know
Yep,
it's
it's
Tennessee.
yep, I know, and that's when you
Yeah.
tell people that in neuro and even in, neurosurgery, they had initially offered me 80,000 and
Oh.
as a new grad, and that wasn't acceptable for me, but then
Yeah.
the second offer was only 103. So and that's in neurosurgery even. I do feel the corporate medicine practice lowballs everybody, and you either accept it or you find a different job,
Yeah.
unfortunately.
I wonder about new grad. Like you came out and you went new grad into neurosurgery, but I'm sure you can kind of extrapolate that to neurology. Do you feel that can be a good move or is a good move for new grads to come out and go straight into a specialty? Or do you think looking back that it really would have been better to do like a year of family practice or something beforehand?
It's always a good thought process when you're trying to figure out your first job. I do think, regardless of whether you do neuro as a new graduate or as somebody with 20 years of experience in family practice, there's just so many little nuances to try to figure out. It's difficult no
Yeah.
matter which way you go. And at least as a new grad, you're still used to studying a lot. You mean you have to study a lot. Stat Pearls is also another online resource that just takes a lot of bulky information and pares it down to digestible material. And they also give you questions that you can access for free that help challenge your knowledge. And then Medscape does mock patient encounters that you can walk through to help prepare you as well. So those are two resources that I use a lot at the beginning too, because you can access them for free. You don't have to buy anything. You don't have to do a subscription to anything.
So, talking about new grads and people coming out of PA school, if they have an idea that they want to go into neuro, especially when they're in didactic year, what rotations do you think are the most helpful for them to get if they can't get a neurology rotation?
You see a lot of the emergency side of neuro in an intensivist role or a hospitalist role or even the emergency medicine. Since you're already going to have an emergency medicine rotation, I would encourage PA students to pursue a opportunity with an intensivist, especially if they have a neuro ICU in a hospital or even a hospitalist, because a lot of things that are admitted to the hospital end up being neuro problems. And so at
Yeah.
least gives you a good idea of how to work those patients up. Now, your acute care of neurological diseases is very different than your long term care, but those would still give you a baseline and you get to practice a really good neuro exam regardless. There is a lot of overlap between a lot of different fields, and you
Yeah.
can really hone in on your neuro skills almost in any field that you practice in as long as you focus on that. And if you hone in on that neuro physical exam and you really get that good physical exam, you can bring neuro to any field, really. There is definitely an overlap between ortho, between rheumatology, even psychology. It's really getting those physical exam skills down and that thought process of these are my differentials. All right, now how do I rule out all these different things without
Yeah.
ordering a whole bunch of tests? And
Yeah.
that's that physical exam.
Anything else that you want to tell people about neurology or why you think maybe they should consider this as a specialty to go into?
Don't be scared about it. It's not that scary of a field to go into. And you see more neuro patients in whatever field you're practicing in right now than you really think you do. So just be confident in your skills. And if you're struggling with something in neuro, I always tell my students to just kind of break it down to the basic facts. The neuro exam can be very, very simple. You're just testing somebody's mental status, cranial nerves, motor, sensory, reflex, gait, and coordination. If you remember those categories, you can do a good just overall exam on anybody. Once you get the field and you understand it, you understand most other body systems too, besides just the neurological system. It's a very exciting field and it's a very humbling field. And you work with so many great patients that, again, just have so much resilience. it's a very rewarding field to go into.
If neurology seems interesting to you, but you're wondering if maybe neurosurgery would be more for you, then you can check out this video here. And I also have an upcoming video on pediatric neurology. When I get that done, I'll put that video here at the end as well. Thank you so much for joining me today. And as always, take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.